welcome back. This is actually the second video of my hard health video series. So the first video we talked about, what happened and getting a blood clot, then a stroke, and in this video, I'm trying to get the light out of here. In this video, just kind of want to talk more specifically about the low ejection fraction discovery. So, I did talk about it in the first video, but the main thing is that after I left the hospital, the very next test they wanted to do, they did want to rule out any blockages that they couldn't see with some of the scans. So let's see, that was in November. And then so in December, I had a what they call the heart cath. And that's where they actually went through my arm in two different arteries to, get over into the heart and look for blockages. So, it's a painless procedure and the way they put you out. I mean, you're kind of not fully out. You're actually laying there, and you're watching all the TVs. And you're kind of in and out. That procedure really left a lot of bruising on the arm. They actually had trouble getting into one of the arteries where they wanted to go in, so they had to go in a different way. And I think with all that, that had a lot to do with the the bruising that I ended up with. So there really wasn't any concerning blockage. I mean, I remember on one of the pictures he circled an area that there was 50% blockage somewhere, but unless it's 75%, apparently they're not really concerned. 50% sounds like a big deal to me, but apparently it wasn't a big deal. So gotta watch that cholesterol. So and then the next step was to really wait and see what the meds would do over the next few months. So 6 months later, that's when I had the ultrasound or the heart echo done again. And that was in like early May, I believe. So the goal there was to find out if the percentage of low EF had improved with the medication. And so again, I was under 20%, and coming through that, it was only 25%. So unless it hit 30%, basically the recommendation was that you had to get an implant defibrillator. One of the other things that they discovered with my situation back when also was that the low EF, the slightly enlarged heart, were two things, but also the lower left chamber was not beating strongly enough. It wasn't in sync with the right side of the heart. So with the recommendation of getting this ICD implant, it required a third lead. So the two leads that are kind of normal, I think, are really for kind of more the pacemaker side of the defibrillator, in case you did have cardiac arrest, and that's the shocking. But with mine, with the third lead, that was into the left bottom chamber of the heart. That actually required a specialist. He was actually out of Tulsa, but that was for the third lead, and I'm trying to remember the name of the term, but it was a electrocardiologist, I believe is the term. And so that third lead is basically constantly pacing that side of the heart with the right side, right, to keep them in sync. So I had like low conduction, and that was kind of this additional issue that I had. So that required actually a little bit different device. The device I have is by Abbott, and I'll talk more about that in the third video. So they recommended all that. Basically, the next step was just get it scheduled and get it done. And ironically, it's funny, there's been a lot of changes with the doctors in cardiology here. My original cardiologist, when I started this, had left abruptly in January, and I got another one. But since he's not an electrocardiologist, he's just an interventionalist. They had to recommend the specialist, and the specialist did happen to do the procedures over here in Springdale, Arkansas, at Northwest Hospital there. So I was able to get that scheduled. But then I must have been one of his last procedures because that was June 3rd, 2022. And then right after that, I was notified that they were actually closing down the practice. So he was actually closing his practice down and moving to be closer to the family. So I won't mention his name or anything like that. But never see him again. So he did a fine job with the procedure, and he was good at what he did, of course. And then basically all my follow-ups are just with my normal cardiologist here. Okay, so all that to say, the next step was really to go ahead and get the device. And so I thought I'd include some video here that just kind of talks about the hard echo procedure. There's a lot of different information you can search on and watch videos. This one actually just kind of talks about, and it does a nice job of showing the different angles of the heart and the way they do the procedure. It's a simple enough procedure. I don't know, probably took 20 minutes. And then, like I said in my first video talking about it, they're not a cheap procedure either. And so I guess it's why a lot of us don't ever really have that just done and look for things like this. Although, after experiencing this, I would highly recommend everybody should have one of these done, because it's one of those things you don't know if you're walking around with it. And I don't know that there's another test they do that really detects it from what I've learned to this point. So that was, again, just all part of the story and why it's interesting to me, and I'd like to share that part. All right, well, I think that's it for this one. I'll show a couple pictures, but I think the third video showing the implant and having it done and all of that is starting to get even more interesting. So thanks for watching.
It's my hope today that we can kind of break down a comprehensive transthoracic echocardiogram to manageable pieces. There's a lot involved. Let's go ahead and get started. The first thing I'd like to cover is the standard windows. There are really 4 standard transducer positions that we use in transthoracic echocardiography: the parasternal, the apical, subcostal, and suprasternal. The sonographer may sit at the right or left side of the patient and scan with either the right or the left hand. Digital acquisition standards should be a 3-beat clip. This gives us an adequate representation of anatomy and physiology. Longer clips may be acquired as needed, especially in patients with irregular rhythms like atrial fibrillation, or in cases of pericardial disease and Doppler. The measurement standard should be, if a patient is in normal sinus rhythm, we should measure 3 cycles and average them. If a patient is in atrial fibrillation or an irregular rhythm, measure at least 5 cycles and average those measurements. Let's start with the parasternal window. The hash mark on the transducer is on the left, and you can see we have a nice view of the left ventricle. By rotating 90 degrees in a clockwise fashion and tilting a little superiorly, we can have the short axis view at the level of the aortic valve. By moving slightly inferiorly, we're actually moving into the left ventricle. This is the short axis view at the level of the mitral valve. By either angling or sliding down a little further toward the apex, We then see the left ventricular short axis view at the level of the papillary muscles. And by sliding even a little further out, we have a very nice view of the very apex of the heart, or the short axis view at the apical level.
For more information on other programs in the Tutorials in Echocardiography series, as well as other educational series, please visit our website or email us at the information shown on the screen. Thank you for joining us.